There we go. So hello, everybody. Welcome to one of the Therapath's Lunch and Learns, virtual Lunch and Learns. Very glad to have everybody here today. I'll be co-hosting today with our wonderful Robin Harp. She's one of our therapists here at Therapath Mental Health. And she's actually going to be presenting most of the content today because cPTSD is very much treatment of cPTSD is very much focused on psychotherapeutic interventions, which are so important. But we're going to discuss a little bit more today about kind of the pharmacotherapy potentials, as well as what may be appropriate or not, and most importantly, how to collaborate together on providing multimodal care for these patients who can be have very complex needs. So with that, I think we'll get right into the slides. And again, as Julia said, as questions come up, you're more than welcome to put any questions in the chat, and I'll make sure to keep an eye on them and answer those as we go. Okay, a little bit of background about me. So my name is Arif Noorbaksh. I go by Arif unless I'm prescribing medications to you. I'm a Texan through and through. I did my undergrad at UT Austin, did my MD at UT Houston, and did my residency in psychiatry at UT Southwestern here in Dallas, Texas, where I'm based. My email address is included here if you have any direct questions. Always happy to collaborate with anybody. And I have no specific disclosures for this presentation today. Robin, if you'd like to introduce yourself.
Yes, so my name's Robin Harp. I am a clinical social worker and I am a supervisor, so I'm making sure they got that on there since that means you can count this towards your 50% required education credits that are given by a supervisor or a few other things that you're supposed to be. I'm also an EMDR therapist and consultant. And so when I talk about therapy and complex trauma, it's going to come a lot through that lens, but there are other ways to think about it. So I'll try to add that too. And I have no disclosures except that I'm a little nervous. So.
No problem. Thank you so much, Robin. Appreciate you being here and participating. A little bit about what we're going to be talking about today. So we're going to define what complex PTSD is, discuss how that definition came to be. We'll discuss and then Robin will discuss comorbid issues that you might see in treating PTSD patients, treatment challenges that you might see, as well as the evidence-based treatments for cPTSD. And then I'll hop back in and talk a little bit, again, a little bit because it's the more minor part of treatment of PTSD, pharmacotherapy considerations and how I think about pharmacotherapy when I'm treating patients with this condition. So a little bit about what is complex PTSD or cPTSD. So first and foremost, let me just say I come from a background of like very evidence-based, DSM criteria-based training. And what I found as I've kind of advanced in my career is that there are this large group of patients who don't meet criteria for PTSD, formal DSM-5 PTSD. And it's usually because of the criterion A. So if we talk about the cause of complex PTSD, it's prolonged repetitive interpersonal trauma. And so this is very important and can be very different from how DSM describes the kind of criterion A, which is exposure to actual or threatened death, serious injury, or sexual violence. And so there's this large subset of patients that don't meet that criteria, have an extensive and repetitive trauma history, and have symptoms as a result. And so when we talk about kind of what those symptoms are, what's important to note is that cPTSD now has kind of a defined definition in ICD-11, which is nice to see. It was considered for inclusion in DSM-5, but ultimately they decided for all the complicated reasons they decide things in DSM not to include it in the DSM-5, but maybe included in subsequent editions. But the core symptom clusters are your standard PTSD symptoms, so re-experiencing symptoms, avoidance symptoms, hypervigilance symptoms, in addition to what are called disturbances in self-organization, or DSO. And this includes affect regulation, so kind of emotional volatility, difficulty with self-soothing. This includes negative self-concept, so a really pervasive shame that can be a big risk factor for other comorbidities that we'll talk about later, as well as guilt and worthlessness. And then disturbances in relationships, so difficulty trusting or maintaining relationships or closeness with others. But the most important thing here is that the trauma is developmental, it's relational, and the core task is to kind of repair, relational repair, and the establishment of a coherent sense of self. And so that requires a very multimodal approach to care, both from a pharmacotherapy standpoint as well as from a psychotherapy standpoint. Robin, is there anything else that you'd like to add to this definition?
No, just I'm so glad that ICD-11 has come out with a complex PTSD diagnosis and criteria, and I really wish that our electronic medical records would finally convert to ICD-11 so we could actually use it. That would be great.
Yeah.
But yeah, I see so many people who have all the symptoms of PTSD, but they don't have that near death for them or someone else, or sexual violence in childhood. I will, if I poke around long enough, I can usually find something that I can say would get them a PTSD diagnosis. For instance, oh, mommy chased daddy with a knife and threatened to stab him or kill him. I think that, and you were there and saw that, I think that was fear for your father's life and you were afraid he was going to die. So I will diagnose them with PTSD. That's because there's nothing better.
Yeah. So a little bit, and I'll turn it over to Robin now. Comorbidities and treatment challenges.
Okay. So you have the obvious comorbidities of depression and anxiety disorder. So with depression, as we know, it's the negative concept of self and the world and everybody else in the world. I'm horrible, everyone's horrible, the world is horrible. And then the hypervigilance. So lots of clients will say things like, oh, I'm so anxious, I'm so anxious. And I explain to them that PTSD and those symptoms are like anxiety on steroids. And that usually helps. They have a hard time understanding the hypervigilance part. Why am I so jumpy? And so a lot of psychoeducation about the symptoms and normalizing. A lot of people will say, no one else has this but me. No one else does this. There's something wrong with me. Nope. Everybody does it. That's why I can pretty much tell you what's going on with you when early on. Often there's substance use disorders, self-medicating in order to numb themselves or keep themselves leveled out a little bit if they have some volatile mood. Somatic symptoms. So what we know from back the original ACE studies, trauma gets stuck in the body and it affects your nervous system. And it's going to take more than not thinking about it to change that. I have been reading recently that I can never say this word, bear with me, fibromyalgia is, which, they've not figured out where that comes from, but now some people are saying, maybe that is trauma related. And I would have to say, duh. So we've got to help people learn to release that from their body and kind of reset their nervous system. That's where I usually start. Okay. So dissociation is a big part of it. I do usually just assume people dissociate when I first start to see them, and then it's a matter of how much do you dissociate. Lots of people know, most people don't know. So we'll talk later on, bring up some assessments, but I will use one usually, which is called the DES-2, and it goes through questions like, do you ever find clothes in your closet that you don't remember buying? Do you get someplace and you don't remember how you got there? So I will explain to people, we all dissociate. Sometimes we get home from work and we're like, oh, did I stop at that stop sign? I do not remember. I was like off somewhere else. And it's a spectrum all the way from that to I have multiple personalities. So everybody, all of us, trauma or not, falls in that spectrum somewhere. And I explain to them that it is a protective mechanism. It's why people forget things, bad things that happen to them. It is a way to regulate themselves. So, we talk about depersonalization, derealization, and wherever else they fall on that spectrum. And I just normalize it all for them as something that their brain did to help keep them safe, try to protect them for things they weren't ready for. Derealization, depersonalization, feeling unreal themselves, or like they're detached from everything else. Emotional numbing. So I see that a lot. People sort of turned off their emotions. And in order to make progress in therapy, we've got to get those turned back on. I usually start by checking in with the body. Okay, where do you feel that, if you're feeling sad or you're angry, what happens to your body when you're feeling that? If they can't, then I'll ask them a question like, where do you think you would feel that in your body if you could feel that? So we're trying to turn their emotions back on, which is really scary for people who have been numbing their whole lives probably. Makes them feel out of control. I just normalize that too. And sometimes things have to get a little worse and uncomfortable before it gets better. And of course, lack of coherent narrative. That is, lots of people will not have memories of childhood, or very few memories of childhood. And of course, as a child, if you're growing up in chaos, you don't want to, it's not in your best interest to be angry with or hold it against the people who are supposed to be keeping you alive. So you don't want to, oh, my mother was a wonderful woman. That's interesting because she was physically abusive, or just even, verbally abusive. I personally think verbal abuse, emotional abuse is just as destructive, if not more so, than physical. So that's where we are with our memories. Treatment complications. So dissociation, you got to have people in the room with you in order to work on their past. So helping people learn to stay in the room, to stay present, is a big part of phase one, stabilizing. Sometimes you think you've got somebody stabilized, they're more present than they used to be, they're a little more regulated than they were, and you start working on processing, and then something comes up that sort of spins the work out of control, and you have to go back to working on stabilization. So it's very, it is not a straight line. Yeah, that's what I'm trying to say. The work is not a straight line. Next. So I like to talk to people about distress versus danger. So when you have been through chaotic childhood, everything is scary. The brain is amazing and also kind of dumb in some ways. And what it doesn't know is the difference between emotional danger and actual physical danger. So my body, my heart is beating a little fast right now because I'm a little nervous talking to people who aren't even in the same room with me. So I know I'm not in any physical danger. However, my brain doesn't get that. So it has turned on my stress button. And when somebody is stuck in may have been actual physical danger, or may just been repeated emotional danger that the brain thought was physical, people cannot tell the difference between just this is a little distressing versus I'm in actual danger and someone's going to kill me. And the fight, flight, freeze gets triggered. And their emotions can get very labile. They can have a lot of relationship issues with other people. And so just trying to get them oriented, is this just some distress? Like, this is a little uncomfortable. And it would be uncomfortable to anybody versus I'm going to die. So work on that with them. Neurological basis. So the prolonged inescapable trauma leads to chronic activation of the hypothalamic, I don't know if I said that right, pituitary adrenal, which is called the HPA axis. So basically, that's our nervous system kicking in. And the more times that has happened, the quicker it happens, the easier it happens, until you've got people living in fight, flight, or freeze basically all day long. And we want to get them back to a relaxed state. So the amygdala, which is our alarm bell, gets over responsive, lowers the threshold for fear. So again, distress seems like actual danger. And there was something else I was going to say. There have been studies, the amygdala of people who had a lot of childhood trauma, actually larger than the average amygdala. So it not only changes your thoughts, it actually changes our brains and our nervous system. So next slide, please. So now let's talk about some treatment and assessment. Thank you. So a lot of people go with a phase-oriented approach. I don't know that there's any evidence that one is better than the other. Some people, especially in EMDR now, are like, you can just jump right in. That's EMDR 2.0. Don't jump right in if you just are trained in standard protocol, I would say. But it's usually best to stabilize people first. So you want to, that's where also the relationship building comes in, because we're working with clients who don't have a lot of trust, and we need them to trust us so they can be present in the room and have some feeling of safety. We want to do affect rate regulation skills, so basic coping skills, grounding, establishing, hey, you're really safe, even though you may not feel like it, you are in this situation. And yeah, to keep them coming back to therapy, they need to feel safe. They need to mostly be in the room, emotionally, mentally, physically. And then the next phase is the processing, which is the intervention. It's all intervention, but there you go. And then understanding who you are, because you did not get the chance to develop a sense of self if your life is chaos. And here's where talk about it's cyclical. You might say EMDR, you might be able to work on some big trauma things and then kind of get stuck, and you realize, oh, there's like a little kid part there who's throwing a monkey wrench in things because they don't feel safe and they get activated when we bring up some of this stuff that's a little more difficult. And so I will use ego state therapy to kind of, what can we do in EMDR? How can we help that child learn to soothe themselves? How can we install, was there anybody who ever provided some safety for the client? Did they ever get nurturing from anyone? Is the client nurturing to their own children? Can the client imagine their adult self nurturing the child self? That's actually the one I have the most luck with. And I, send them home for the week to practice taking care of their younger parts. Sometimes it's a teenager, and that's more difficult because teenagers are naturally difficult. But then you can go back to processing. Hope that makes sense. There's a lot of back and forth with complex PTSD. Next, evidence-based intervention. So, trauma-focused CBT, which is cognitive processing therapy. However, trauma-focused CBT is more focused on writing the narrative and then helping people pick out the unhelpful thoughts, stuck points, negative self-concept, shame, blame, all of that stuff. And while you're doing that, you also use some self-compassion skills, helping people learn to have some compassion for themselves because they probably don't. My favorite thing, I like to use people's children and loved ones against them. So like, okay, if your kid was here and said, I'm a horrible person because of XYZ, because this thing happened to me, what would you say to them? I'm like, oh, that you're not terrible. This was something that happened to you. You had nothing to do with that. You weren't responsible for that. You were just a kid. Like, okay, so now can you say that to yourself? Because we're way nicer to other people than we are to ourselves. And yeah, so the shame is a huge piece, and shame is like the hardest thing to move. Those maladaptive, again, goes back to those maladaptive beliefs about yourself, others, in the world. DBT skills are great to work on affect regulation, and some tolerance, interpersonal stuff. Mindfulness, I think mindfulness is the closest thing we have to magic. And it's hard to get people to do it, but if they will, it's amazing. It raises the distress tolerance naturally and helps you sleep and all kinds of good stuff. So oftentimes you're going to have to do some DBT type work with people before you get as part of the first phase. EMDR, so it's 8-phase treatment that uses probably most people know what it is, but that uses bilateral stimulation. Some people are now saying dual attention. So eye movements are tapping. There's also accelerated resolution therapy, which is another version. Brain mapping is kind of similar. I just happen to be trained in EMDR, so that's what I do. For those who do not know, the original thought was that traumatic memories do not get processed like a regular memory. And EMDR brings up the ick again with the image and the feelings and the physical sensations. And then we say, okay, now process it. And the brain does it. However, there are other thoughts that it also may work by the eye movements are kind of a neutral job for your brain to do. I call them brain squirrels, when it goes running off somewhere else. It gives the brain squirrels a job. If they're doing a job, they cannot run off. So that's sort of neutral information. And so your brain is weaving that neutral information in with the traumatic information, which decreases the distress, discomfort, ick around it. So there's that. And I also like that it helps, lots of times you can know something in your head. You can know, okay, it wasn't my fault that my uncle sexually abused me when I was 5 years old. You can know that in your brain, that a 5-year-old has nothing to do with that. But your heart doesn't get it. Your heart's like, I should have done something different. Grandma said it was my fault. I'm a horrible person. So it helps to make that connection from your heart to your brain. So your heart actually gets it too. It is, if you are trained in standard protocol, it is great for single big T traumas. But how often do we see someone like that? So one of the ways to use it for more like relational themes, and your mother called you, said you were stupid thousands of times. We can't do every one of those as a target or we will never finish. So I like to jumble all of those up into a ball and then kind of pick out the parts that are most disturbing. It may not all be from the same times to work on those. It's just another little nuance. Next. A couple of few assessments. Actually, there's a few more that I forgot to put on here. But the International Trauma Questionnaire is one that is aligned with the ICD-11. So the first part assesses for those traditional PTSD symptoms. And the third part assesses for those DSO clusters, which is the issues with affect and regulation. And now my brain just stopped, but those three things. The dissociative experiences scale, that's the DES2. I don't give it the way it was designed to give. I don't really care about their score. But if somebody answers Yes, I do these things 30% or more of the time. I want to talk to them about it. The questions are, some people have a lot of trouble with the questions and they do not understand what they're answering. That's the first problem. I've had people who are older and there's a question, do you look in the mirror and you don't recognize who you see? And they'll say, yeah. And when you ask them about it, it's because, oh, it's not because they have another personality. It's because I can't believe I sold. So you got to kind of pull all of that apart. There's some others that people traditionally have trouble with. But that gives me an idea of how much they dissociate and how they dissociate. We talk about what causes that, what triggers that, when do you dissociate? And that's how I use that assessment. There's another one that is more extensive. There's the mid 60, which is 60 questions. And then there's also the regular mid, which is, I can't remember what it's called right that now, but yeah, MID, if you Google MID and dissociation, it'll come up. It's 200 and some odd questions. And I've had one person actually complete that. Thank you, Rebecca. So that is the DES2, and then the difficulties in emotion regulation scale. It's pretty much what it says it is. Do you have a hard time managing your emotions? And goes through some different scenarios. So those are all good ways to get an idea of what you're working with. Next. Ah, good.
Thank you so much, Robin. Um, so let's talk a little bit about some pharmacotherapy considerations and how I think about medications when I'm treating patients with cPTSD or PTSD, really. Um, so a few things to think about. So initial considerations. Medications are not first line. The evidence and the research that we have suggests that these are not as effective in both the short term and the long term as psychotherapy, of various types. And the research is can vary depending on what they're studying, but psychotherapy is the initial treatment that's preferred. When you look at the studies comparing medications to psychotherapy, or even combination of medication and psychotherapy, what you find is that all of these approaches, medications, psychotherapy, and the combination beat placebo. But they don't really separate out from each other very well. And when you look at long-term outcomes, especially, the medication-only arms tend not to do as well as the arms where psychotherapy was included. And so just trying to emphasize here that when I'm treating patients with cPTSD, kind of therapy is steering the ship. And I'm just here to provide support in specific ways. And we'll talk about what those specific ways may look like. So the only exception to this in the studies that I came across actually are patients who expressed a preference for pharmacotherapy only over psychotherapy. So some patients, for whatever reason, are not interested in engaging in psychotherapy and want to just pursue pharmacotherapy or medication management to treat their symptoms. And in those patients, they tend to do better on medications versus psychotherapy or the combination thereof. And so that's something to think about a little bit. And I kind of think about my job in those situations as psychoeducation, building rapport, and trying to get patients to a place where they are more comfortable kind of engaging in therapy. Because therapy for PTSD and CPTSD can be really, really painful. and uncomfortable. And so it's understandable why there's avoidance around it. But I try to really kind of guide patients that direction if I can. So what do medications do then? I think about it as being a tool just to facilitate psychotherapy. Oftentimes there are situations where symptoms are so severe they're not able to engage, like Robin was talking about, especially if you have like a very strong disassociative component. If the volume of emotions is so loud, it's overwhelming and they can't really function, that's going to be a difficult thing to engage with from a psychotherapeutic standpoint at times. I think of my job as facilitating psychotherapy rather than the other way around. Again, this must be a collaborative approach, so we want to work together, and oftentimes we do to talk through patients, their cases, and what their needs might be, both bidirectionally, both from a med management to therapy provider and from a therapy to med management provider. The other kind of consideration as part of this facilitation of psychotherapy is that there are medications that can actually disrupt the psychotherapeutic process. So a lot of what's happening in the treatment of cPTSD from a psychotherapeutic standpoint is learning. We are learning, we're breaking up former associations and learning new ways of associating and reacting. Learning is really important, and medications that can be really acutely effective and are very tempting to use, like, benzodiazepines, like Klonopin or Xanax, et cetera. These aren't medications we use very often in general, and they're medications that can really inhibit the therapeutic process. I remember when I was doing my residency working in the VA for a rotation in the trauma clinic. There was one therapist in particular that had a very strong rule about if they're on a benzo, I won't treat them. They must taper off their benzo before we'll start therapy. I think that speaks to how seriously some clinicians may take this. Thirdly, targeting specific symptom domains. So a lot of what I do when I'm working with patients with cPTSD is not necessarily treating the cPTSD per se, but treating some of the symptoms that are really barriers to engagement. So depression and anxiety, like Robin spoke about before, can be big ones. Sleep, poor sleep, frequent nightmares. If you're exhausted, you're going to be emotionally brittle. It's going to be much harder. Hypervigilance is something that we can try to manage if it's extreme. And then I've had many cases, well, I don't want to say many, but a lot of cases of patients presenting with cPTSD who are exhibiting symptoms of psychosis, whether that's just delusions or whether that's frank, experiences like I'm seeing people in the backyard that are trying to break into my house and hurt me. That's a much more extreme kind of situation, and could be a potential safety concern. And so that's something that I'd want to treat in the short term until they can get a little bit more stable, and we can work on symptom management a little bit better. And then lastly, kind of as a corollary to this, targeting comorbid conditions. So it is very common for people with cPTSD to have a comorbid depressive disorder, anxiety disorder, or a substance use disorder. I read a study, and studies in cPTSD are kind of uncommon right now because it's until. Sorry, Robin?
It doesn't exist.
Yeah. So it's without kind of, now we finally have in ICD-11 some kind of diagnostic criteria that we can use and study. But in one study that I looked at in cPTSD, the rate of alcohol use disorders or alcohol dependence is upwards of 50%, which totally makes sense to me. If you're experiencing what these patients experience on a daily basis, they would be looking for self-soothing in some way. They don't have the internal tools, and so they're looking for external tools to help manage these symptoms. Substance use disorders are really common. And we don't have to wait. So a lot of places want to treat the substance use disorder first, and they want some period of sobriety before we start trauma-informed therapy or some kind of psychotherapy for cPTSD. And the data suggests that's the wrong strategy. These are kind of bi-directional relationships between substance use and PTSD symptoms. And if we don't address the root cause that's driving the substance use, how are we going to get to a place where we can engage in therapy more productively? So treating both concurrently is very, very important. A few examples of specific medications we can use. Won't go into too much detail here because there's a lot, and this could be a whole lecture on its own. But when we're talking about depression, anxiety, hypervigilance, that symptom domain or those symptom domains, SSRIs have the best evidence. There's some evidence for SNRIs or Effexor, venlafaxine specifically. But by and large, first-line treatment when you're dealing with these situations is an SSRI. Things like Zoloft or sertraline, Prozac or fluoxetine, those kind of things. In addition, for sleep disturbance. So this is very common and probably one of the most common symptoms I treat in CPTSD is sleep disturbances and nightmares, because these patients very frequently just aren't sleeping. The most commonly studied agent is prazosin. It's been studied extensively in many different populations, including veteran populations. And like all studies in psychiatry, especially medication studies, it can sometimes be hard to generate a positive result in a study for a variety of reasons. But prazosin has good evidence to help suppress nightmares, help suppress and help induce sleep, so these patients can get more restful sleep. How it works. So Robin talked a lot about the HPA axis, sympathetic nervous system function, and how the sympathetic nervous system can get really revved up in the context of cPTSD, and this happens especially during nightmares. And so prazosin and another agent we use sometimes called clonidine, these are both old blood pressure medications, work by kind of blocking the sympathetic nervous system. So the sympathetic nervous system can't affect the body, can't induce like the tachycardia, the high heart rate, the high blood pressure, the sweating, etc., that can happen during a nightmare. And so it reduces sympathetic nervous system tone. And then prazosin in particular can also be helpful, even when dosed just once at night, to reduce kind of daytime symptoms of sympathetic kind of overdrive, like hypervigilance, for example, and those kind of symptoms. So this can be a helpful tool to help patients get to a place where they're more able to engage in the psychotherapeutic process and it's more productive. And then psychosis. Psychosis again is not uncommon in cPTSD and PTSD. And so what we use typically are second generation antipsychotics. Quetiapine or Seroquel is kind of the most common and has the best evidence, but we also use risperidone. I've had very severe cases where I've had to use stronger antipsychotics like olanzapine or Zyprexa. Those are kind of the primary agents we use as far as psychosis and in PTSD. But they're almost always used as an augmentation agent. So adding them to an SSRI. Excuse me, I lost audio here for a second. So adding them to an SSRI to help augment what that SSRI is doing. All right. I will say also that these agents, I very frequently get patients who come to me who don't have psychotic symptoms who are on these agents. These are higher risk agents. They're agents that I like to get people off of as soon as possible. And so that's one place where we work together, trying to identify exactly what symptom domains were these agents were being used to target, and working with therapy, their therapist in collaboration to try to target those symptoms specifically so we can get them off things like risperidone, especially as quickly as possible. and then a few things that don't have good evidence. And then a few things to think about a little bit that don't have great evidence right now, but people are trying to develop evidence for. And so, in the category of limited evidence or negative studies, things where things are actually worse at times when these medications are on board, benzodiazepines are probably at the top of that list. So we talked about learning. So technically, it's called extinction learning. And so having benzodiazepines on board, especially benzodiazepines like Klonopin or like Valium that last for days in the body. We want to minimize that because it makes psychotherapeutic approaches less effective. Um, there used to be some thoughts that beta blockers, which directly block the sympathetic nervous system, how it acts in the body. So it doesn't reduce sympathetic outflow. It blocks the sympathetic nervous system for actually doing what it's trying to do in the body. So there was a lot of hope that beta blockers, if you could block these episodes or symptoms, it could really improve quality of life. But those have all been negative. Mood stabilizers, things like lamotrigine or Lamictal, have not been found to be helpful in the context of cPTSD. They have been found to maybe be helpful in other comorbidities, certain personality disorders that might evolve, but not directly for cPTSD. And then this is the big one, cannabis. So I have a lot of patients who come to me with PTSD on cannabis, and they're asking me for medical marijuana cards, which I don't write. The reason is that the data suggests that when you're using cannabis to manage these symptoms, just like alcohol or just like any external substance, you are inhibiting your own ability to develop internal coping and internal management of these symptoms. The use of cannabis is something that I discourage in these patients. I get why they're doing it. It kind of numbs things up and helps you feel good for a period of time. But in the long term, we're not going to get to a good place. And our goal is remission, remission without needing to use external mechanisms to get there. Cannabis is probably close or at the top of the list with benzodiazepines. And then there's a few investigational agents that I thought were interesting just to talk about real quick, that are actively being researched. Probably the most well-known of this is MDMA. MDMA and MAPS, the group that was researching MDMA for use in PTSD, did a large phase 3 clinical trial using MDMA plus their own specific kind of therapy protocol. They didn't use a standardized protocol that's available. And that study was positive, but had a lot of methodological issues. And the FDA ended up not approving MDMA for the treatment of PTSD. But I'm quite certain somebody else is going to take a swing at it. And the thought is when you do MDMA or use MDMA for trauma focused care, it's like you have 2 preparation sessions, you have 2 therapeutic sessions with MDMA on board, and then you have 2 integration sessions thereafter. And so the idea is that you're kind of forcing the brain into a place where everything feels good, and then engaging with that really traumatic content that doesn't feel good, and potentially breaking up those associations and that reflexive response to that content. So kind of desensitizing to that content in a way, chemically, as compared to, like, for example, what Robin was talking about with EMDR, using kind of eye movements as a neutral to try to help prevent that reaction as well. Ketamine is something that has some evidence for PTSD, but the evidence isn't robust. I've treated a few patients with really severe PTSD symptoms with ketamine. It requires, in any of these interventional treatments where there's an acute intoxication like MDMA or ketamine, you have to do a lot of prep work with patients, because these patients kind of at baseline are prone to not feeling safe. And giving them a disassociative like ketamine, for example, can really be traumatic. can really be disruptive. And so it's not something just to go out and seek, willy nilly. I'm just gonna go to the corner ketamine clinic and get an infusion and see if that helps. This really requires a very collaborative approach to care. So psychedelics are coming, whether it's going to be for cPTSD or PTSD first, or other indications. We'll see, but they're on the list. Also, interestingly enough, we talked about beta blockers not being effective as kind of just like a daily use medication for PTSD. But there is some interesting studies showing that if you use it during therapy, it might be helpful in terms of kind of preventing that trauma response and that sympathetic kind of overdrive response while you're trying to process those traumatic memories. Those studies are kind of hit or miss. But it's something that's being actively researched. You might see stellate ganglion blocks being advertised by anesthesiologists all over the place as a solution for PTSD. What a stellate ganglion block does is they actually use a fairly long needle, go into the neck and anesthetize the part of the nerves that control the sympathetic nervous system in the body. So far, I've seen some case studies that have been positive, but no randomized controlled trials that have been significantly positive. So it's something that's still being actively investigated. And then, interestingly enough, there's been some positive studies with acupuncture, which I'm all about, kind of low impact, low risk interventions. So acupuncture could potentially be a viable, adjunctive treatment for a lot of these patients. All right. So we have a few minutes left for questions. Thank you all for listening. I want to open the floor.
I had a quick question for Robin.
Yeah.
I don't know, Robin, if you remember me. We
I do.
facilitated. Yeah.
I saw your name pop up. I was like, "Ah, yes, thank you for answering the mid question too. There's a link to the mid in the chat that Rebecca added.
Yeah, I had a question for you. So, at some point you had mentioned giving your client the homework of nurturing that inner child. Do you have some examples of what that would be?
Um, it sort of depends on the client, but one thing that I usually try to do is like have them walk through what would be the inner child, whatever age that is. Where would a place be that they feel really calm and relaxed, has all their favorite stuff, their favorite food, their favorite toys, or video games? What is it that they need? Do they need guards? Do they need grandma? If grandma was the nurturing presence, does grandma need to be there? And so have them come up with that. And then I will use tapping because I want them to tap when they go home. So that's why I use tapping and not eyes. And have them practice that. So it's kind of like calm place visualization, but it's for the kid.
That's great. Thank you.
Mm-hmm.
Other questions today?
I had a question. For medications for sleep disturbances, how long do you typically like to keep them on?
That's a really good question. So I like to, what I'm usually targeting is insomnia and nightmares. I usually go for 6 to 8 weeks initially. And then I like to trial off of the medication once they've been in therapy for 6 to 8 weeks. They've worked on things a little bit just to see where we are. Because unless you stop it to test, you're never going to know. And if things are still problematic, you can always restart. But there is concern, and I've become more and more convinced that there is no like safe sleep medication. In a lot of ways, they all have their drawbacks. Natural sleep is the best sleep, and so we're just trying to symptomatically control those nightmares to improve quality for a little bit. But I certainly don't want it to be a long-term medication. Yeah.
Cool, thanks.
Yeah. Any other questions or concerns today?
I have a question. Once somebody has psychosis, I heard you mention that you don't like to keep them on these mood stabilizers for a long time.
Yeah.
If somebody has a bout of psychosis, I had once heard from a psychiatrist that they are pretty much needing to take medication for the rest of their lives. Have you seen some indications that that may not be true with intensive therapy?
That's a really, really good question. And I'll let Robin chime in on this too. She has some experience. Uh, uh, in the context of a primary psychotic disorder like schizophrenia, the answer to that question is yes. They will likely need to be on medications for the rest of their lives. If they have a single psychotic episode, so outside of PTSD or kind of a trauma response, that has a decent likelihood of recurring. But in the context of PTSD specifically, all the delusions and psychosis I've seen have been around safety and concerns of safety. And it's kind of like a manifestation of just the dysregulated internal state that's going on. And so I have had good luck with getting patients with the assistance and collaboration of therapy to a place where they're doing much better and then peeling that off without it recurring. And so I think it's diagnosis dependent is probably the right answer to that question.
Yeah.
Thank you.
And I would say that the kind of delusions, psychosis that you see in PTSD, cPTSD is very different from the like schizophrenia. So what we see in PTSD is more like shadows or something. I saw something move out of the corner of my eye. They don't see a demon coming at them.
Yeah.
It's very light. Also, if it's audio, they are hearing their name called, or they're hearing the voice of their grandmother.
Okay.
Yeah.
So it is not the kind of like, hurt yourself, hurt somebody else. It not the kind of scary psychosis that you get with schizophrenia. It's a very different flavor.
Yeah.
It is hard to convince them that it's not like schizophrenia psychosis because they've probably been told that a lot. And so it is hard to get them to move from that without some medication.
Well,
Okay.
I appreciate everybody for coming today. It is 1:00. We do need to wrap. Thank you so much for being here. If you have any follow-up questions, my email address is available to you. And we really appreciate it. Thank you so much.
I'll be sending an email out about CEs and also when the video is posted so you can watch it and recap or share it with a colleague. And again, you can always reach out to me as well if you have questions about today's event. So thank you so much.
Thank you.